Well, I have the great honor of introducing Dr. Taubman. I'm Tom Tesserero, class of '81. I actually started in Rochester the year that George Engel's seminal article was in 1977 was written. So I grew up with a biopsychosocial model. I thought it was just an incredible set of lectures this morning. It all struck a note in different ways for me, including just the environmental, because I had a dinner with my brother 2 nights ago in New Jersey, and we went to a restaurant and they said, "Do you want tap or bottled?" And I said, "No, I want tap." And my brother and sister-in-law said, "You don't drink the water here. There's stuff in it and you cannot drink it in Bergen County, New Jersey." So, okay, well, good morning. I'd like to acknowledge that this is Dr. Taubman's final State of the School address, and to recognize his really remarkable service for more than a decade as Dean of the School of Medicine and Dentistry, and as CEO of the Medical Center. In fact, he is the first person, if you don't know, he is the first person in the history of URMC to serve in the dual role as both Dean and CEO. Previously, he was the Charles E. Dewey Professor and Chairman of Medicine from 2007 to 2010, and the Paul Yu Professor and Chief of Cardiology Division. And in addition, he was the director of the AB Cardiovascular Research Institute and the director of the Center for Cellular and Molecular Cardiology. As CEO, Dr. Taubman was the first to create and implement an integrated strategic plan for URMC. It stretched across all 3 missions, reinvigorating the foundations of core patient care, research and educational activities, and significantly boosting commitments to diversity and inclusion efforts. He led a strong and successful faculty leadership recruitment focus, and he assured a renewed emphasis on financial agility by establishing the medical center's first integrated financial model, which recognized the interdependent missions and ensured support for the academic enterprise. I mean, clearly you can have a vision, but unless you have the money to fill that vision, it's not going to happen, and Mark did both. During Dr. Taubman's tenure, the medical center has seen tremendous growth with over $1 billion in capital projects that have transformed the campus. In recent years, his steady and reassuring leadership was essential to the university, particularly during the challenges of the COVID pandemic. He's worked with Monroe County public and health officials to structure a coordinated community health plan. He dedicated medical center resources to build tools and infrastructure to support screening, testing, and equitable distribution of vaccine within the community and surrounding regions. I don't know if you can remember back a couple of years ago when we were all fighting to see who would get the vaccine. He graduated from NYU, completed his residency in cardiology fellowship training at Brigham and Women's. He was also served on the faculties of Mount Sinai and Harvard Medical School. He and I were both born in Brooklyn. Most people don't know that. He is an international authority at vascular biology and research institutes in arterial injury, thrombosis, inflammatory chemokines, and cellular aging. So, and I just want to thank you for the incredible legacy you have continued to build for our school. Thank you, Mark.
I think really the thanks go in the other direction. It's been an honor to do this. It was not something that I actually envisioned when I came here. I really thought I would be chief of cardiology and I'd be maybe chair of medicine, and but circumstances are such that I wound up not doing cardiology, not doing basic research, but having the pleasure to run the medical school and to run the medical center. And I hope to, in usually the state of the school is just so you see what we look like. And I do think you've already gotten some sense of what we look like from our 3 speakers. I will use this a little bit to give you some perspective on what has changed. I'm going to start with education. And just, I think, make it clear that we are not just an undergraduate medical school, even though we are celebrating our 50th reunion. We're still a relatively small school. We take 105 students a year. That puts us in the bottom 25 percentile. But it means we have one of the largest faculty to student ratios in the country. We have a large graduate program that really has grown. So you actually have more graduate students than we have medical students. We are in the 90th percentile in that about 9.5% of our medical students go to get MD, PhD. So that's very high percentile. But you see, we get about 70 PhD students a year. Our residency program now has grown to 95 residencies and fellowships. And we will hit that 900 number very, very shortly. So it's a very large residency program. The School of Nursing actually has about 700 students in roughly a dozen programs. That actually went down in the last couple of years, and they've seen, like everywhere else, a decrease in the number of people going into nursing, which is a little bit frightening given the shortages that we have currently. And we continue to see a rise in our dental school, which is all residents, postdocs, and masters, not an undergraduate dental school. And we now have a faculty of over 2,000. So it's a broad educational program. Just to show you about your school, the medical school, we pretty solidly get somewhere between 5,500 and 6,000 applicants a year. That represents around 10 to 11% of all people who apply to medical school in the United States apply to Rochester. The other 90% have made a mistake. We have about a 5.8% acceptance rate, and something that I heard when we were giving out the medals that your class of 80 had eight women for the last 5-6 years. Actually, it's been about 50%, 50 to 51% women, and between 17 and 20% underrepresented medicine. So a very different class look than you've had. One of the things, just to let you know, is that next week we are re-upping for accreditation. Since I've been here, we've had 2 cycles of accreditation. We both times got 8 years, which is the longest we got. The first time when they were allowed to make positive comments, which they're not allowed, the comments was, "This is as close to a perfect medical school as they've seen." That was nice. Last time you just sit there and they tell you the problems. But we're looking forward to another 8 years. In terms of graduate school, I think what you also see is a remarkable increase in the number of people applying. It's tripled in the last 5 years. And I think that is a representation of the quality of our faculty and the greater notoriety of the University of Rochester's research programs. As you can see, interestingly, in our graduate school, it is predominantly women, and with a actually high for this country underrepresented in medicine. Just to let you know what happened in our match, we had 102 students graduating. What was interesting is that we had the highest number of students staying at the University of Rochester than any time I've been here, 31%. And, I don't know if that's partly because in COVID, you tend to circle the wheel and stay where you are, or I'd like to believe it's because they know that this is a great place to stay, a great environment, and in particular, under difficult times, we have thrived. And I think that's important. In terms of the match, as you might imagine, about 80% of people get one of their top 3 choices. What's interesting is internal medicine went up. It'd been around 10, 11% for the last couple of years, and now we have an increase, but you can see what they're into. In terms of our residency programs, we now have 95 programs. We've had about a 13% growth in residency programs. What you see is about half of our residents go into fellowships and about half go into practice. Half of those are academia. The other half are in private practice. If you look at what our fellows do, roughly 45% go into a non-academic practice, about 40% go into academia, 13% are gluttons for punishment and do another fellowship. It's very mixed. And when we got the AAMC results, turns out that we're in the 90th percentile in graduating people who stay in academic medicine. But we are also in the 88th percentile in people who actually serve in underserved areas. So I think we are serving our mix of trying to generate the next generation of academic leaders, and at the same time, providing workforce that is socially conscious. What's interesting about us as a private institution is if you look at the people who do go into practice, roughly 52% stay in New York, and the majority of those stay in Rochester and work in one of the two systems, though predominantly ours. That's pretty high for the privates, more typical of a state school. So people seem to like to stay in the area, which I can understand, because people thought when I got here, coming back, having left Boston because going back to New York because it was too small, didn't have enough music and had the wrong baseball team. They were betting that I would last weeks. I think the outlier was 6 months, but I very much learned that once you get here, you don't want to leave. What's ahead for education? What do we see happening in the future? There's going to be fierce competition for the top students, especially diverse students and faculty. There are a growing number of free or discounted tuition schools. We are extremely low endowment related to a lot of our peers. We're not in a position to provide tuition free unless somebody comes up with a $500 million gift. We are being challenged, obviously, by the new SCOTUS ruling, and there'll be obviously pressures to renovate, just like in 75 when Strong Memorial Hospital was the model of a new hospital, and now it needs to be redone. Same thing with the medical school. We're going to need to redo the facilities. Where do I see that taking us? I think on the research side, we need to increase the number of training grants so that we can attract the best graduate students. We're going to need to continue to focus on diversity and value-added education. And there is where I think we particularly take advantage of the fact that the medical school is on the campus of the university, and provide for a 4-year education, provide the clinical piece in 3 years so that people can use their 4th year to take advantage of the university, to get a degree in the Department of Public Health Sciences, in the Warner School of Education, in biomedical engineering, in the Simon School of Business, so that what we offer may not be free tuition, but it is something very special, something that Laney was talking about in terms of potentially a master's in bioethics. So I think that's where we're trying to move. We are developing rural health residency because we have developed a large network, and hopefully that will be helpful in supplying workforce to the greater area. And one of the things that we are really interested in doing is opening up a small undergraduate dental program, taking advantage of something like what Harvard has. We don't think we need another undergraduate dental school that generates hundreds of dentists, but rather 15 or 20 who get a DDS and a PhD. And because our dental school really is growing as one of the major still research intensive dental programs in the country. I'm not going to say much about this because you heard Lainey talk, but I think we're very, very pleased that we have a new Department of Health Humanities and Bioethics. Another area that I think you heard a little bit about, but really is becoming a major collaboration, is the Eastman Performing Arts and Music Program. And it really has 4 areas where we actually treat performing artists who have various types of injuries, both to their hands and vocal, to use the performing arts to create a ideal environment in the hospital. So now you have musicians who are playing for the patients, but they're also in the lobby of the hospital. Almost everywhere you go now, you will hear music. And I have to say that I walk in, I know there are 100 challenges I'm going to face each day. It's nice to walk into music. We are, the third ring is really music and art therapy, which I think is very, very important to treating patients. And the last is research, to really try to understand what we can do to prevent injuries to musicians, and what we can do to use music and the arts to further improve healing. So I think, I hope you see that this continues to be extending the biopsychosocial model. On the research side, we are a very large research institution. We have currently about $267 million of NIH funding. Actually, that number is higher because you find out things in October, that because that's when the government fiscal year ends. Around 55% is NIH funding. That number has gone down because we're getting much more funding now for clinical trials as we become a clinical trial center. You can see we have about 3,000 grants and contracts. And again, the majority of those would be clinical trials, but we have 1,000 NIH grants. I think something very interesting, we have a faculty of 2,000, we have 780 who are listed as investigators on grants. So about 40% of our faculty, despite the pressures, are involved in grant-funded research. And we have about 300 of our faculty who are principal investigators on NIH grants. Like most of research-intensive institutions, we invest about 60 cents on the dollar. And that's over and above what we get back from indirects and other things. So in our case, that's about $167 million a year to support research. You heard that one of the things we did is have a fully integrated budget. It's not a negotiation. It's a line item at the top of the budget, and same with education. So even at a time like COVID, we were able to support. We maybe didn't do new recruiting for a while, but we were able to support everything. But the majority of that, because we're not so well endowed, comes from clinical margins. And that's a challenge. One of the things that was very important to us was if we are going to be increasingly a center, the center for academic medicine and research in upstate New York, we need to grow our clinical trials. You see that we developed a clinical trials office, which we had not had. We developed clinical trials software. And as you can see, the number of dollars we've gotten in clinical trials grew when what was remarkable is one of the few places that grew during COVID. You see that drop in 2023, and that's workforce. That's because we couldn't get enough clinical trial nurses. That has rebounded somewhat, but it's something that, again, is a consequence of this workforce shortage. But this year, it will exceed, we believe it will exceed 50 million. And again, that's very important because not only is it important academically, but it brings patients here. It provides the region with protocols. You know, my dream is that you never have to leave Rochester to get the state-of-the-art care for anything. And that means be able to provide the clinical trials. One of the concerns I had when I became dean was we had a reverse pyramid, meaning normally you're supposed to have the most number of assistant professors followed by associates followed by full. But as you see in 2014, when we started our strategic plan, it was just the reverse. The blue line is the assistant professors. There were 84 of them, as opposed to 164 full professors. And that worried me because we needed to continue to have a vibrant research program. And it had been challenged in part because there had been reductions during the Great Recession. And so one of the challenges we had was we had to reverse that pyramid. But at the same time, that means trying to get really great assistant professors, some key full professors who can attract them, because potentially, while you're investing in them, your funding may go down because it takes time to get funding. What you see here is we've been successful. We've gone from 84. The blue line is now in the middle at 133, and the slope keeps going up. And I do believe we are on track to get back to what is the right pyramid. Interestingly, if you see below that graph, that represents funding per investigator. So despite the fact that we put most of our resources behind recruiting new assistant professorships, we actually increased our funding per investigator each year, and that keeps happening. We also had focused in the past on programs of excellence, not research in an individual department. So in that first slide, we had about 17 programs of excellence, which represented, they're multi-departmental, multidisciplinary, some crossed over to the River campus, and represented about 95% of our funding. We decided that really to focus on 5 for the last 10 years, and that's been cancer, with a goal to get NCI designation, and we believe we are close. During that time, we've grown into one of the larger cancer centers in the country. Neuromedicine, musculoskeletal disease, RNA biology, and immunobiology. And all of those have done spectacularly during this 10-year period. We became the first institution in the United States in a dozen years to receive a Center for Intellectual and Developmental Disabilities Research, and that was part of the neurosciences program. Again, we are, I think, well on our way to getting NCI designation. Our RNA biology program is world-renowned, and the leader wins almost every year a new prize. We're one of the few centers, respiratory centers, that got an NIH CDC grant. One of the things that was interesting is that we got notified during COVID from Google that our website for COVID research and for respiratory infection is one of the top 5 hits in the country. And they asked us to be one of the centers that answered questions for them on COVID and respiratory diseases. Our musculoskeletal program remains one of the top in the country, and they got a new building that they want. But where we're going to go forward is to continue to support these programs of excellence, but to build new research centers. You heard today from Paige Lawrence on our Center for Human Health and Environment. 2 years ago, we started an aging center, which again is cross university. We now have a new Office of Health Equity Research. We have a cross-campus program in vision restoration. The dental center has developed a oral and craniofacial science center that already is grown into one of the top 10 funded in the NIH, and we believe will be #1 in a few years. And the School of Nursing is growing its research program substantially. We are going to need to expand. For those who haven't been here for 50 years, you see a lot of research buildings here, the Kornberg building, the Del Monte building. We've outgrown it. We're going to need a new research building to expand our cancer program. We need to double the space for our cancer research and our RNA biology program, but we also now need extra space for our clinical trials and our health equity research. How do we fund this? Well, one of the things that we tried to do was to take some of our reserves, which normally just sit and get no real interest, but they're cash. So they are important for our cash on hand, important for our credit rating. But we were able to take some of our reserves and put them in what we call the Academic Reserve Fund, put them in the secondary endowment where they do generate revenue. And that fund has grown to about $300 million and generates between $15 and $17 million a year to support the academic missions. We'd like to increase it. What stops us is if we increase it more, we would drop our credit rating. So what about the clinical? I started with the research and education, and as you well know, it is really the research and the educational excellence here that drives the clinical, that brings the best and the brightest to create programs that ultimately are not only good clinically, but generate the resources to support the education and research. So what we have grown into is a very large clinical network. We have Accountable Care Network, which and you can see where the offices are. There are about 250 locations. And what this Accountable Care Network, which we call Accountable Health Partner, includes roughly 1,800 docs from our faculty practice, which is now an integrated faculty practice, which is also integrated financially with the medical center. But this also has roughly 700 community docs. So we have roughly 2,500 docs, which is a little bit more than 50% of all the docs in the 9-county area. As you can see, roughly 600 or so, 650 would be considered primary care, adult, pediatrics, and OBGYN. So still roughly 70% are specialists. And again, that reflects what we are as a research-intensive, specialist-intensive academic medical center. What this allows us is to provide one standard of care throughout the system, throughout what's become a large network. It also allows us some negotiating room with commercial payers, but really it's to provide a standard of care and to work seamlessly as we've grown into a network. We've also grown, we have now grown into a fairly large system. I look at Larry Smith, who oversaw Northwell. It's not Northwell, but it is a $5 billion operation that now has 9 hospitals. You see those hospitals outlined by the U of R insignia. The last one was Finger Lakes Health, which has hospitals in Geneva and Penn Yan. So at this, we also have collaborations with other health systems, which you can see in Stripe, particularly with the Bassett Health System in Cooperstown in many areas, particularly cancer. So we now have, and you can see the number of visits, et cetera there. So this is, what this does is it allows us to take care of predominantly about 600,000 lives. We have about 1 million charts, and increasingly, we actually have value-based contracts with our commercial payers. About half of our, about 2.5 billion, have risk contracts, and it's the Accountable Care Network that allows us This network was, our creating a network was invaluable during COVID. We really were able to shift load and use this network to maximize our ability to take care of patients in a 9-county region. What our real goal, though, which is critical, we run at about 120% occupancy and have been over 100% for 5-6 years. What the goal here is to build programs in the region so that more and more patients can stay locally. It's obviously good for the patients that they don't get sent to Strong and Highland, so that we can use Strong and Highland to take the high-end referrals, to take the patients that George Alfieri needs to take. When things get tough, we are turning away 100 patients a month from all of over upstate because we don't have the beds. But we don't want to do that. So this really becomes a win-win by building programs locally and shifting cases that don't have to come here. We can act more as the referral service that we are. We started out with 1 urgent care center with 10,000 visits. We now have 13 that had 210,000 visits. And this is just to give you some idea of what this network, this network to look like for our specialties. So we now have 12 branches of the Wilmot Cancer Institute throughout this network where you can get infusions. In certain places, you can get radiation therapy. So again, what it is for the patients is rather than have to come up here, they can have their treatment at home, same high quality, be taken care of by doctors locally, and only have to come up here for the kind of things that we have to do, that we want to do, the marrow transplants, the CAR T-cell therapy. So we would like this to be a model for all our specialties. We'd like to be able to show you that this is what orthopedics looks like. This is what ophthalmology looks like. But that's what we strive for in a center. During this period of time, there's been a lot of growth. The Children's Hospital, we just added a new addition to Highland, which allows it to be all private. We have a new imaging science building. And we built other buildings as well. But we're in the process of 2 huge projects. I hope you did see the Orthopedics and Physical Performance Center, which opened in December, and in a couple of months for surgery. In a couple of months, we'll move all of the faculty there. It really is state of the art. It has motion sensing equipment that is only available in 3 or 4 places in the country, and allow us to create the most specialized type of surgery. It also allows us to shift all of our orthopedic surgery there so that we can accommodate the growing need for general surgery and other specialty surgeries that are outpatient. The hole in the ground you see includes the office I started in. For some of you who know it, it was called the staff house. That's now the hole in the ground, which will be our new ED and patient tower. It'll quadruple the size of the ED. Every room will be private, and it'll be modular. It'll allow us to have all private rooms because we'll renovate Strong into private rooms. So ultimately, we'll have all private rooms, and allow us, if necessary, to have another 150 beds. Because again, increasingly, we are seeing all eyes turn on the University of Rochester to supply the high-end care. What do I see ahead? I could have shown this slide 10 years ago. I thought at this point we'd be moving from fee-for-service to really value-based, where we got paid a certain amount per patient, and it would all be then based upon quality. That if we could take care of patients well, then we'd have the resources left to do the high end. It means that profit centers become cost centers and vice versa. And one of the things that drove every institution to become larger, to create a 9 hospitals, 600,000 live more program, is so that you would have enough very healthy patients, and you would be able to keep patients healthy, keep them at home, do preventive medicine, so that in a value-based system, you'd have the money to do the high-end procedures. And that's really what partly drives the whole initiative. When is this going to happen? I don't know. I thought it was going to happen already. I think it would require a very different government right now. It would require congressional leaders who talk to each other. It would require people to really tackle healthcare. And we're not in that environment now. I think we're moving slowly, though, no matter what. As I said, about half of our business is now value-based, but narrow windows, about 5% risk. But I do see, in order for us, we're not going to keep, we're growing in revenue by patient revenue by about 10% a year because we've grown. We can't keep growing. There's no place to grow. We're going to have to get value out of this, and getting value out of this means also taking more risk. So what do I see coming up? You heard about the biopsychosocial model 2.0. We got network integration 2.0. We now have to take this 9 hospital system and this physician network and really move more and more towards value-based care, providing high quality health services as close to home as possible. We need to restructure post-acute and long-term care. We are watching a nursing home crisis in the United States. It's particularly bad here. When I say we have 120% occupancy, and that's true with Rochester Regional, because every day we have 80, 90 patients boarding who can't get to nursing homes because they don't have the staff. And that's part of the workforce shortage. And yet we have all these referrals coming in. So one of the things that we are really working on is developing new models of subacute and long-term care. That we're going to have to change our model. In our system, we have 8 nursing homes. We can work in that system, but we really have to take advantage of digital medicine. We take advantage of potentially AI to really change the way we do post-acute care. We need to expand our Eastman Dental Center. More and more places are jettisoning dentistry because most of the patients are Medicaid. They lose. 75% of our patients are Medicaid. We now have waiting lists for certain procedures for 4 years. So we need to expand our dental center because I believe it or not, we will probably be it in Western New York. But we also want to develop a small undergraduate dental school. And we still want to be the academic dental center in upstate. I wish we had 2 more floors on Children's Hospital. They are also running over 100% occupancy all the time. And just like dentistry, what we're seeing is smaller hospitals jettisoning their pediatrics. In New York right now, 54% of all pediatrics in New York is Medicaid. So what are they doing? They're saying, all right, we can't take care of it. The Eye of Sauron looks at the University of Rochester, and we're it, and we'll do it. But it means that we've got to expand. A few other mentions. One is culture. Obviously, that's very part of the biopsychosocial model. We've talked about value-based and quality. We have created over the last couple of years a Quality and Safety Institute, led by our Chief Medical Officer, Mike Apostolakis. I'm not going to go over all of this, but it gives you a sense of the robustness of this, particularly in developing the data analytics that really allow, and the research that really allows us to understand what are the best approaches to maximize quality and safety. Another part of our culture stems was the adoption in 2021, the creation of an Office of Equity and Inclusion, of a very, very robust equity and anti-racism action plan. It has 5 really objectives, but the major ones are to make every person feel welcome and supported. For those Rochesterians, we want to be the Wegmans of academic medical centers, where everybody wants to come. We want to be a place where everybody can identify with. And we want to be a powerful force for tracking health equity. We have developed this office. We've set expectations, supportive tools for intentional recruitment and retention. We developed mechanisms to capture actual demographics and social determinants so we can deal with the zip code issue that you heard earlier. We now a committee of the board of the medical center board just on healthcare disparity. And we have a health equity steering committee, and which looks like this, which oversees this, and that includes a new health equity research committee, institute a health equity technology task force, which gets us the information that we need in terms of data to make intelligent decisions, a provider task force to look at how we improve access, and an education task force, which is not just to educate us, but to help work with the community. And all of this works directly with community leaders. The last part, which I did mention, was a wellness program. I think everybody knows that a big issue in medicine around the country is burnout and wellness, increases in suicide. It's a different generation with different expectations. COVID was a very, very difficult experience. And just like we have for equity and inclusion, and just like we have for quality, we want to develop the same kind of robust wellness program. We just hired a new leader, Craig Rooney, signed on yesterday. So I don't have his picture yet. He comes to the University of Missouri at Columbia, where he really built a robust wellness program, and we're very excited that he will be coming. So I think in a nutshell is what our medical center looks like, where I think we're going. I don't know what time it is. Where are we? What? All right, I can take some questions, but I hope this gives you some sense of your School of Medicine and Dentistry.
Hello. Hi, my name is Hanadi, and I had one question that I was really curious about. Are there any proposal about conducting clinical research beyond the geographic of New York State? So for instance, doing projects or clinical trials in developing countries to like expand the academia, but also to acquire more data?
I think the short answer to that is yes. I think that's very, very important. I think that, one of the things that Paige didn't have a lot of time to talk about was that, part of the goal of the environmental health program is to do exactly that. We do have some very, very large programs that we have developed. Our new head of infectious diseases actually spends his focus is on cerebral problems with HIV, and most of his research actually is in Africa. Same thing with Gretchen Bierbeck, who actually I think is the only neurologist in Central Africa, or has the only MRI in Central Africa, has done a lot of research and is trying to expand that. So I think the answer is absolutely. And I think it's an opportunity that more and more of our leaders are going to do. Yes.
Here's the funding model for the future that you just talked about. Is anyone getting insurance companies, physicians, and is anyone getting insurance companies and physicians and the pharmaceutical industry together? Because you have to change the whole economic model to do what you were talking about in terms of your vision for the future.
Not directly. I mean, obviously pharmaceutical companies fund research. And, when you look at the $270 million of funding we have, roughly 20 million of that is pharmaceutical funding. But, one of the problems with direct costs, even when they're indirects, they really don't cover the full cost of research. And I really don't see getting a lot of traction with the pharmaceutical companies. I mean, we're having enough trouble with 340B pharmacy, which is critical to us, and having them buy in. The model is problematic. When I started, it was about 28 cents on the dollar, but that was at a time when the NIH budget had doubled. Right, the flattening of the budget for 13 years has doubled that, and the increases are only really keeping up the increases in cost of living. They haven't made up for that loss. Clearly, the challenge here is we need a lot more NIH funding. Right now, how are we doing it? When you talk about the insurance companies, they actually don't have the money to do it. But, we had a total clinical margin last year. Well, I'll give you an average year. Total clinical margin, maybe $200 million. Our total medical center margin is 80 because we're using that money to support research. Where is it coming from? It's actually coming from the insurance companies, because we lose 48 cents on the dollar on Medicaid, and we lose about 20 cents on the dollar on Medicare. So where is that margin coming from? That margin is coming from 340B pharmacy, and it's coming from the insurance companies. But I believe that the right answer to this is we've got to change the model, because to have the support of academic medicine coming from clinical is a problem. We're too expensive, right? We're now almost 20% of the gross national product. The money we spend on healthcare is more than the gross national product of France, of Germany. I mean, it would be a country. It would be one of the richest countries. It's 2 to 3 times more what our peers in Europe get, but for no better quality. And we're going to have to cut that. We're going to have to do it by improving value. We're going to have to do it, hopefully, by having a greater partnership with government. But with those kind of stresses to do that, we got to find a different way to make sure that the academic, to support our residents, to support the training of medical students so they don't have $300,000 of debt. So this is going to take a real serious discussion. It can't be one part of how do we reduce healthcare costs and at the same time protect what is just and we saw it in COVID, what is a stunning research enterprise. What we are able to do now is mind-boggling, not only in terms of developing a vaccine, but what I see happening is all these cancers that when I started training were death sentences, and now I see everybody surviving. They get immunotherapy, you have stage 4 metastatic melanoma, and all of a sudden you see somebody fine. So, and that's science. And with technology, with AI, we got to figure out a way. I guess one more, and then I think we get to our crown jewel.
A slightly futuristic question. Because you are so advanced in the psychosocial sensitivity, and since we don't have enough nurses, And since eventually we are going to have robots taking care of older people, I'm wondering if you have in any of the discussions you have thought about how you can influence that technology in terms of the sensitivity that's required to take care of this much growing older population.
It's certainly a major part of our discussions. I mean, I sort of alluded a little bit of it, that one of the things that we're actively discussing is how do we handle post-acute care in particular? How do we replace potentially nursing home care? And that's a lot of that is taking care of patients at home, which means taking advantage of the technology, which is getting only better and better, whether it's monitoring devices, whether it's using AI. I do think that one of our goals, again, being as integrated as we are, is we're working with the nursing school to develop programs to develop more nurses, even though there may be a shortage, because, I think a lot of our efforts are going to be, how do we use the technology to make things easier? So that I do think that you're probably right, because in the long term, anything's possible. But I think we saw in COVID how important it was for the hands-on. You don't feel the same when you get touched by a robot than you do by a hand. And in the same way, maybe at some point, a robot will be able to walk into a room and really understand, does that patient look sick or not? Do I need to do something right away, or do I have time? So I'm not looking, I don't think we're looking forward to the robots, but I think we are looking forward to exactly what you're talking about. Here, we are now giving, the School of Nursing is now has a program where they take people with BAs in other fields, give them a 1-year course, tuition free, as long as they sign on to work for 3 years at Strong or Highland. And that program cost us, but it attracted a lot of attention. I think so. I think it's two-pronged. We, as an academic center, have to provide approaches for to recruit nursing. But you're absolutely right.